Hi, my name is Jessica Schultz, and I'm going to be talking to you about twin-twin transfusion syndrome today. So for objectives, I want you to be able to describe the mechanism of the pathophysiology that occurs in twin-twin transfusion syndrome, describe the key effects that TTTS has on the fetuses, identify the diagnostic measures that are used, and analyze the staging scoring of a fetus and identify appropriate treatment measures. Alright, so TTTS is a progressive and severe disorder that results in the imbalance of circulation between the twin fetuses and can result in a number of different things. It can be seen at any point during gestation, but it is most commonly seen in the first trimester, and the earlier the diagnosis is seen, the more severe the disorder seems to be. TTTS should be diagnosed as early as possible in order to ensure the best outcome for the mother and both fetuses, and counseling on the risk to the fetuses is crucial in management of this disorder. For epidemiology, about 1/3 of twins are monozygotic, so meaning that they come from one egg that has split into two, so identical twins. About 3/4 of these twins have something that's called monochorionic diamniotic pregnancy that I'm going to be referring to as MCDA from now on. And that means that you have two babies with two amniotic sacs, but they share the same placenta. Only about 8 to 10% of these pregnancies are at a significant risk for TTTS. This isn't a very common disorder. About 1 in 3 births per 10,000 happen. This makes up for about 17% of total perinatal mortality in twins and about half of perinatal deaths in twins that have MCDA. So the core pathophysiology of this disorder is something called abnormal arterial-venous connection. So you have a donor fetus and a recipient fetus. In that donor fetus, there is an artery branching off from the umbilical cord to the placenta, and ideally there would be a vein coming back from the placenta to the umbilical cord, delivering nutrient-rich oxygenated blood. But instead, in TTTS, that vein is going to the umbilical cord of the recipient twin. So that donor twin is transfusing large amounts of blood to the recipient twin, and that leads to the imbalance of blood between the twin fetuses. So the donor twin will end up becoming anemic, and the recipient twin will end up being polycythemic. Another issue that happens is, since there is so much blood going to that recipient twin, the blood will be thick since they are getting so many red blood cells, and that can lead to problems. So let's look at the more specific effects that this blood imbalance is going to have on the fetus. So the donor twin is not going to be able to perfuse the organs since they are not getting a lot of oxygenated nutrient-rich blood. And it will start diverting blood to the most important organs, so the brain and the heart, and shutting down other less vital organs, leading to organ failure. The most common and first organ that the donor twin will show to be shutting down is the kidneys. They will be making very little urine, and over time, if this is untreated, eventually they can be making no urine at all. And as we will see in the staging process, whether you can see the bladder of the donor twin on the ultrasound will increase the severity or the staging level, because if you cannot see the donor bladder, that means that the donor twin is no longer making urine. Oligohydramnios versus polyhydramnios. So since the amniotic fluid is made up of majority of urine, since the donor twin is not making very much urine, the donor twin will have oligohydramnios. And since the recipient twin has so much blood being pumped to it, it is going to try to compensate by peeing out a lot of urine. Therefore, they will have polyhydramnios. Also, the recipient twin will be fluid overload, and their blood will thicken since they are getting so many red blood cells as well. It can lead to the heart having a harder time pumping the blood and lead to heart failure, general soft tissue swelling, and possible fetal death. So since the twins do share blood vessels, if one twin dies, there is a significant chance that the other twin may die or have lasting neurological effects. Loss of one fetus is relatively common, and there's approximately a 10% chance of losing the other fetus. Even if the other fetus does not die, there is a 10 to 30% chance that the surviving fetus will have a neurological defect and a 40% chance of brain injury if that one twin does die. So, for diagnosis of TTTS, you need to have two core findings. The first one is the presence of monochorionic diamniotic pregnancy. So that's what we talked about earlier, where you have two babies, two amniotic sacs sharing one placenta. You also have an ultrasound that shows that one twin has polyhydramnios and the other twin has oligohydramnios. So the donor twin, if you look at the donor twin's amniotic sac via ultrasound, you'll see the deepest pocket of amniotic fluid that they have is going to be less than 2 centimeters. And in the recipient twin, the deepest pocket in their amniotic sac is going to have greater than 8 centimeters of amniotic fluid. Other supporting features of this disorder, but are not specific to it, is usually the recipient twin will be drastically different in size and weight. They'll be a lot bigger and they'll have unequal placental sharing. So the donor twin will have a smaller portion of the placenta. A lot of twin pregnancies have this, so it has led to a lot of misdiagnosis. However, accurate diagnosis is crucial for the management and treatment of this disorder. So for screening in the first trimester, we're going to first confirm MCDA and do an NT screening. From what I can tell on this NT screening, it's just a normal pregnancy screening that every woman has, called a neutral transparency screening, which measures the fluid on the back of the baby's neck. And it's been shown if you have an excess amount of fluid there, it's been linked to genetic abnormalities. Then around 16 weeks, you're going to start doing ultrasounds, and in these ultrasounds, you're going to be measuring the maximum vertical pocket in each amniotic sac. You also want to look at the fetal bladder of each fetus, and because remember, in the donor fetus, we're concerned about its renal function and being able to see that bladder to see if it's making urine still. And if the maximum vertical pocket is greater than 2 centimeters but less than 8 in each amniotic sac, so they're still in the clear there, we're going to continue to do ultrasounds every 2 weeks until delivery. However, if the maximum vertical pocket is less than 2 centimeters in one amniotic sac and greater than 8 in the other, that means one has oligohydramnios and the other has polyhydramnios, then you can diagnose TTTS. So a widely used staging system is called the Quintero TTTS staging system, and they stage it from stage 1 to stage 5, with stage 1 being the least severe and stage 5 being the most severe. And so stage 1 is just the core diagnostic criteria of less than 2 centimeters maximal vertical pocket in the donor sac and greater than 8 centimeters in the recipient sac. But the donor twin's bladder is still visible, so the donor twin is still making urine. Now stage 2 is the donor twin's bladder is no longer visible on the ultrasound, and they observe it for over 60 minutes. Stage 3, the Doppler studies show critically abnormal fetus in either twin. So either you have reversed or absent umbilical artery diastolic flow, pulsatile umbilical vein flow, reverse ductus venosus, or A-wave flow. For stage 4, you'll have fetal hydrops noted in one or both twins, so that's the general swelling. And then stage 5 is fetal demise of one or both twins. So to look at severity, you can also do a fetal echocardiogram to see if there's any enlargement of the heart or any regurgitation across the heart valves, or decreased function or pulmonary stenosis. And this is mainly in cases that have gone untreated. And then you can also look at the umbilical artery blood flow, mainly in the donor twin, because what will happen is the donor twin's heart can no longer pump hard enough to provide the placenta with blood via their umbilical artery. So since you're not pumping any blood to the artery, you can get no flow or reversal of blood flow back. All right, the primary treatment of this disorder is lasers. What can happen is the mother can go into preterm labor due to complications, and also she can have a premature rupture of her membranes due to that polyhydramnios of the recipient twin. All right, so for laser treatment, as you can see, it really depends on the stage of it. But what happens is you want to eliminate the abnormal vascular connections between the twins. And you're going to do that by directly hitting those abnormal vascular connections with a laser beam that they are going to insert through a thin fiber optic scope into the abdominal wall of the mother, through her uterus, and into the amniotic cavity of the recipient twin. They'll also do a detailed ultrasound before this procedure to help guide the scope and identify the blood vessels that the twins share. So as you can see, for the management, a big thing is counseling. So counseling the parents on the possible outcomes that can happen. The survival rates for one twin is about 85%, and for both twins, it's about 60% with using laser therapy. Also, another option is amnio reduction, and that is when they go in and reduce the amniotic fluid on that recipient twin. And so this is the study that the guidelines talked about. In one group of 144 twins, they got the laser treatment that we previously talked about. And in the next group, 140 twins received serial amnio reductions. So they looked at gestational age and a number of other things. On the gestational age, it looks like it was an increased gestational age at 33 weeks, so the mothers were able to carry them longer than with the serial amnio reductions. They had an increased rate of survival in at least one twin at 6 months of age. They had a decreased rate of perinatal deaths up to 6 months of age. They also looked at neurological development. So in the laser group, there was an increased amount of patients that had no neurologic complications at 6 months. They also had an increased amount of neurologic development that is normal at 6 years of age. Keep in mind there is only 2 of these values that had a statistically significant p-value, and that was the gestational age and the alive and free of neurological complications at 6 months of age. So this is the study that kind of guided the guidelines to determine that the laser treatment is more effective and is a better first-line therapy than having serial amnio reductions and severe twin-twin transfusion syndrome, and if it's diagnosed before 26 weeks of gestation. So when is the best time to deliver these babies? First things first is we want to consider one course of steroids between 24 and 33 weeks and 6 days, especially if they're in the more severe stages of greater than stage 3, and if they're undergoing treatment with invasive interventions, just to try to develop the baby's lungs. Also, there is no real guideline that shows when delivery is best. So it really depends on the staging, the severity, and the progression, and if the treatments are effective for the fetuses. There is one of 2 options. One, you can do a planned delivery at 32 to 34 weeks, or if they're not very severe, so either in stage 1 or stage 2, you can kind of individualize the pregnancy and the care of the fetuses with just surveilling them with ultrasound and delivering them between 34 and 37 weeks. All right, to go into a little more detail on the steroid injection for fetal lung maturation, as we said before, it is indicated for 24 weeks and 33 weeks and 6 days if the patient is at a risk for delivering within the next 7 days. This also includes if the patient has ruptured membranes or multiple gestations. The most commonly used ones is betamethasone and dexamethasone. The betamethasone dosing is IM 12 milligrams every 24 hours for a total of 2 doses, or you can do 4 doses of 6 milligrams every 12 hours. For dexamethasone, it is IM 6 milligrams every 12 hours for a total of 4 doses. So if the patient is still having concern for preterm labor and it's after the 7 days, as long as it's been 14 days and there's still less than 34 weeks gestation, you can do a repeat single course of corticosteroids. And also, based off of the clinical case, you can do it in as little as less than 7 days instead of waiting the 14 days. Now, if they are 34 weeks to 36 weeks and 6 days gestation and they're at risk for having a preterm labor and delivery within the next 7 days, you can do a single course of betamethasone if they have not previously gotten corticosteroids.